questions. Looks like we're recording now. First I'll start out by just telling you a little bit about myself and how I got to where I am right now. And then I'll tell you about MS, which is one of my subspecialties, or multiple sclerosis. And then we'll go over some cases because I know this is supposed to be a virtual shadowing program. So it's important to go over some interesting cases. So I'm Monica Diaz. So I was actually born and raised in Miami, Florida. I'm first generation American. So my family immigrated from Cuba back in the 1980s. I don't have any family members that went into medicine or healthcare. My mom was a secretary at an office and my dad was a car salesman. I grew up bilingual and I spoke English, well, mostly Spanish at home and then English at school. And I actually grew up in like an all Hispanic suburb of Miami. So a lot of Spanish speaking where I grew up. And I was the first person to graduate from college in my family. And then my little sister went to college afterward and she works in tech now in San Francisco. So I didn't really have a real reason to get interested in medicine because there wasn't a strong history of it in my family. But I did have several family members when I was in middle school and high school that were affected by neurologic disease. So my grandmother had early onset Alzheimer's disease. She started to develop symptoms of dementia when she was in her late 50s, so pretty early actually. And my grandfather had Parkinson's disease. So having seen two grandparents go through pretty debilitating neurologic diseases, I really became interested in medicine and in pursuing the medicine as a career. So back in high school, I think that's when I really got interested in it. And then I decided in college to major in neuroscience because I was very interested in the brain. I thought it was the most interesting organ. So this is a really busy slide, but it's also because I've had a lot of different educational experiences. So that's where I went to high school. I graduated in 2004. And that was in Miami. And then I stayed in Miami for college. I went to University of Miami where I did my bachelor's degree, graduated in 2008.
They're not going to get the same from
okay. I don't know if somebody's talking.
Nutritionist. And so like.
Okay, there we go. I hope you can hear me now. So I went to college in University of Miami, did a double major in neurosciences and French literature. And I was a commuter student. So unfortunately did not live in a dorm or get the classic college experience, but that's okay. It turned out okay after all. And then after I graduated, I actually took the MCAT my senior year of college, And I did below average. So I wanted to take some time off after college to improve my score, have more time to study and get some, out of college research experience. So I was a clinical research assistant at Cornell up in New York in the Division of Cardiology. And then during that 2-year period, I spent a lot of time studying for my MCAT as well. Then I did medical school at State University of New York and downstate in Brooklyn, and then graduated there in 2014. And at that point, I already knew that I wanted to do neurology. So did my neurology residency at Yale. But prior to neurology residency, you always have to complete 1 year of internal medicine. So I did my 1 year of internal medicine at Louisiana State University in New Orleans. And this actually varies. So there are some most neurology residencies actually have the 1 year of internal medicine already built into it. So you match into a program and then you're automatically already accepted into that internal medicine year. But there are some programs that don't have that available. So it just depends where you apply. And then after completing neurology residency, I did a 1 year fellowship in neuroimmunology and multiple sclerosis and neuroinfectious diseases. It was kind of like this hybrid fellowship. I'll go into the details of that in a little bit. So I graduated in 2019. And then I went on to do a research fellowship. So I spent 1 year in Peru starting up a research project, and it was a really cool experience. Well, because one, it was the first time that I had lived abroad, but two, it was really a nice opportunity to see have my own study and be able to build it up from the ground up. And I continue to do a lot of work in Peru, and I continue to go back. I'm actually going back next week because I still have several studies going on. So it's a long road. So I added up how many years it took, and I was surprised myself. So 4 years of college, 2 years of the gap years that I took to be a research assistant and study for the MCATs, 4 years of medical school, 4 years of residency, and then 2 years of fellowship. So that's 16 years. It's a long time. But I think it pays off in the end. So I'll go over, this was just my undergrad experience. So, like I mentioned, I was a neuroscience and French literature double major. I had a lot of odd jobs throughout college. I was living with my parents at the time, and studying. I did a lot of work study jobs actually. And, this was actually how I learned that I really loved neurology. Was I had a job working at a front desk of a epilepsy clinic. So it was a neurology clinic for patients with seizures. And I was just the front desk assistant. And I learned that I really loved neurology there because it was my first real exposure to it in the healthcare setting. And then I had other odd jobs. I was a chemistry tutor. I sold concert tickets, all of that, and still studying for my double majors. So like I mentioned, I took the MCAT my senior year and I scored below average. I wasn't too happy with the score. So that's why I took 2 years off after college to try to improve my score. And it did the second time that I took it. I volunteered at 2 hospitals in Miami, about 3 hours per week. And I also had other activities that I was involved in, like like I mentioned, the summer after college, I moved to New York and I got a research assistant job in the division of cardiology at Cornell. And then in medical school, I found that neuroanatomy was my favorite. So you can see the neurology trend. So that was my favorite subject in medical school. And I was always interested in neurology since day number one. There's actually a student interest group in neurology that's available in most medical schools. It's called SIGN for short. So if you're interested in neurology, you can join that. And they have different experiences that you can get involved in, whether it's volunteering or shadowing neurologists in the medical school. And then the summer between MS1 and MS2 year, I did a research summer internship at Harvard, where I focused on a study on diabetes research at the time. And then at the end of your medical school training in MS4 year, that's when you apply and then you interview for residencies, and then you match into residency in March of your MS4 or 4th year of medical school. And then in neurology residency, they're pretty much all structured very similarly. So you do 1 year of internal medicine, and that's required. You can't skip over the internal medicine year, and then 3 years of neurology. I would say years 1 and 2 of neurology residency are the hardest. You spend a lot of time on the hospital wards. You have to do night shifts in the ICU. And then year 3 is better. You got more elective time, clinic time. So it is nicer. It is 4 years, but it goes by fast, especially when you're looking back on it. And I would say most neurologists actually choose to subspecialize. So the trend is that most of them go on to do a fellowship and to do additional training after neurology residency. There are many fellowship programs across the country in multiple sclerosis and neuroimmunology, which is what I did. And then there are only about 5 that have that additional neuroinfectious disease training component. So that's the one that I did. And then most fellowships are 1 year long for multiple sclerosis and neuroimmunology. There is the option of adding on a 2nd year of research. And this is the typical structure of most fellowships. It's predominantly outpatient, so you're mostly in the clinic seeing patients. Very rarely is there a component where you have to go into the hospital to see patients. But most fellowships are structured with 3 days of clinic in multiple sclerosis and neuroimmunology. The one that I did, because there was that neuroinfectious component, you would spend about 1 day a week seeing patients with infectious diseases that affect the brain. There's usually 1 day of research, and then that's usually the setup of most programs. And then you can also choose to do some other electives like neuro-ophthalmology, neurorehabilitation, and those are just some specialties that often we have to work with when we're seeing patients with MS. So like I mentioned, I did that additional fellowship. It was a research only fellowship by the National Institutes of Health, where I had the opportunity to spend a year in Peru and started a study that was focused on cognitive impairment or dementia affecting patients that are living with HIV. And then at that point, while I was there doing the research fellowship, I got the job here at UNC as an assistant professor in the Department of Neurology. So I've been here since December 2020. And there are a lot of, for neurologists, you can be predominantly clinical, so seeing mostly patients in the clinic or in the hospital, or you can do a lot of research too. So that's what I focus on. I'm on the tenure track, which means that I'm expected to meet certain criteria for promotion to associate professor. And then primarily I focus on research. So 75% of my time is spent doing research, and then 25% of my time is spent on clinical work in the outpatient clinic. And then I also co-lead our global health and neurology rotation for residents and fellows, where when I'm down in Peru, a resident can come and kind of observe on the wards with my Peruvian neurologist colleagues that work down in Lima in Peru. So we have that rotation that's currently active. And then just to go over my day-to-day schedule, like I mentioned, I'm mostly research. So when I say research, it's a lot of coordination. So especially clinical research, because I don't do lab. I don't work in a lab. I do only clinical work. So it's a lot of coordination with the research coordinators, being present for different research studies or research visits if needed. If there's a research participant that comes in and we're going to do their evaluation, oftentimes I have to be present. And writing papers. That's another big component of clinical research as well. So yeah, so it's a little bit of everything actually, but I like the diversity. So, and then in the afternoons on Mondays and Thursdays is when I have my clinics. And then and Wednesdays as well. I have a clinic in the transverse myelitis clinic, which is actually a really interesting clinic. It's a clinic that's dedicated to treating patients that have had inflammation or some sort of injury to the spinal cord. So that's the transverse myelitis clinic. So I do a little bit of everything. And then of course, I also do teaching where we have to, give lectures to the residents as well. And usually my weekends are free unless I'm on the hospital service, which you do have to work over the weekend in those cases. And then, like I mentioned, I do go back to Peru pretty often because I have several ongoing research studies that are still going on there. So I spend about 5 months per year in Peru, and I break it up actually. So I'm not there 5 continuous months, but I usually break it up like 2 to 3 times per year. So just contact me if you're interested in global health and neurology. I always have a whole variety of projects that are going on, and I've had several medical students and even one undergrad get involved. So feel free to reach out to me if you're interested. So now I'll start telling you about MS. Oh, I was looking at the time. Okay. So why MS? So I got interested in MS because these were my primary reasons that I thought of. So it's a very treatable disease. I think it's a lot unlike some neurologic diseases that we have out there that don't have great treatments, like Alzheimer's disease or dementia, for example. Unfortunately, we don't have good treatments to help reverse the cognitive impairment or the memory problems that happen as part of dementia. But MS, for example, is really treatable. We have a lot of new effective medications that have been developed over the course of time. I really like this diagram here because you can see that in 1993, there was only one medication available. It was actually an injectable medication, and it's not very effective. And then as time has gone on, we've had more and more and more medications that have been created. And actually, this is a little bit outdated because even back in in 2020, there was a new medication that was approved in 2020, and we have a lot more that are coming down the pipeline as well. So it's a really exciting time to be in MS. It's also a really interesting disease, so I'll share that with you shortly. It also affects young people mostly. So oftentimes, I would say the majority of my patients actually tend to be younger than 30. I would say mostly younger than 40. So it kind of feels like, because this is the age group where, patients or people are really active. So either starting families or, working full time, it's really important to try to keep their quality of life as optimized as possible. So I feel like it makes a really big impact when you can really help younger people not develop disability. And then you can really impact somebody's life. So those are my major reasons for why I went into MS. So what is multiple sclerosis? So it's a lifetime autoimmune diagnosis. So there's no cure. So it often requires lifetime treatment. There are about 400,000 people with MS that live in the United States, and it's estimated that there are about 2.5 million worldwide. And what happens in MS is that there's something called demyelination. So that means that the myelin sheath, I think I have a picture of it coming up, but the myelin sheath that surrounds the neurons, or the connections between the neurons, actually starts to deteriorate. So your immune system starts to attack the myelin sheath surrounding the nerves of the central nervous system. So that includes the optic nerves, the brain, and the spinal cord. And there are some environmental triggers that I'll talk about. So this is just a typical MRI of a patient with MS. So I have a lot of other MRIs to show, but what happens is that you can see here, this is the white matter. So all of this over here, and then you start to see these lesions that start to occur near the ventricle. The ventricle is the space that holds fluid in our brains. And this is what mostly the lesions look like. They tend to be close to the ventricle or out here close to the cortex. So I have other pictures I can show later. And it involves both the white and the gray matter. It's mostly a disease that affects the white matter, but there does tend to be gray matter involvement, which is the exterior or the outer part of the brain. It affects mostly females in a ratio of 3 females to 1 male. It predominantly affects Caucasians or whites, but Black or African Americans and Asians are also affected as well, and Latinos or Hispanics. Males tend to have a more aggressive course and a more rapid accumulation of disability. And I will say that also Blacks and Latinos also have a more aggressive course as well. So it tends to occur further from the equator, and the reason is that, so you'll see here that in the South, there are about 50 to 78 cases per 100,000 people, and in the North, it's about double that. And the reason is because there's a lot of data that has shown that having low vitamin D levels, so you get vitamin D from the sun, having low vitamin D levels is actually a risk factor for developing multiple sclerosis. So that's why, presumably, especially here in North Carolina, like right now, the sun is out and we get a lot of sunshine, but in the colder states, the people are outdoors less, and there tends to be more of a risk of multiple sclerosis with lower levels of vitamin D. And then there are other different risk factors as well. So there is a genetic risk factor, actually. So about 1 in 40 people with multiple sclerosis have a first-degree relative with multiple sclerosis. So that means mother, father, or a sibling. And the risk is higher if the patient already has another autoimmune disease. So for example, if they have lupus, rheumatoid arthritis, or any other autoimmune disease, then the risk of developing multiple sclerosis is also higher. There are environmental risk factors as well. Like I mentioned, low vitamin D levels increase the risk of MS, and that's particularly true in whites and Caucasians. And higher body mass index, or BMI, so obesity, also increases the risk of multiple sclerosis as well. So again, it's what we call multifactorial, meaning there are a lot of different factors that can predispose or put somebody at risk for developing multiple sclerosis. Both genetics play a role sometimes, and also environmental triggers lead to the immune system attacking its own central nervous system. So that leads to loss of myelin and nerve fibers. So this is the picture that I wanted to show before. So these are two neurons or two nerve cells, and the connections between the nerves are covered in myelin, which really helps the nerves conduct impulses between each other. What happens in MS is that the immune system starts to attack that myelin. So you can see here that there's disintegration of the myelin sheath, and then it gets to the point where there's no longer a connection between the two neurons. So that's what happens, what causes multiple sclerosis. And that's essentially because your B and T cells can cross the blood-brain barrier and then attack the myelin sheath. So MS is a really interesting disease because it causes a lot of different symptoms, unfortunately. So the most common symptom is actually fatigue. I would say it's probably the most debilitating symptom, and it's present in about 80% of people that have multiple sclerosis. And it's actually the most common reason why many people with MS have to leave the workforce, because they feel so fatigued that they just can't go through an 8-hour day at work. And it's also a very difficult symptom to treat too. You can have double vision or blurry vision out of one eye, bladder or bowel issues, sexual dysfunction, depression, anxiety, cognitive difficulties, and then also a difficulty with sensation. So numbness and tingling, and then pain are pretty common. What I didn't have here on this list, which I should have mentioned, is that there can also be difficulties walking and difficulties using your arms and your legs. So that's another reason for MS leading to disability. And then here I've just listed the percentage of people in this one study that reported these different symptoms. So you can see that sensory symptoms were pretty common. When I say sensory symptoms, I mean like numbness of an arm or a leg, tingling, or pain. Weakness, like I mentioned, is also pretty common. Visual symptoms like blurry vision or double vision. Diplopia, which is double vision, is also pretty common. And then vertigo or dizziness can be pretty common. And then here you can see the other ones that are less common, but still can be present in about 30 to 50% of people. And then there are different types of MS. So the most common type is relapsing remitting multiple sclerosis. So that means that's this picture over here. And that occurs in about more than 80% of all MS cases. And what happens is that you get a new set of symptoms. So that has never happened before. So that's represented by this peak here that you can see. And then some people return to some people, when they recover from those symptoms, they recover completely, and then those symptoms go away. And then you keep having these relapses or these flare-ups of the disease that continue to happen. There are other cases where people don't return to what we call their baseline, or their the symptoms that they had before. So they get progressively a little bit worse every single time that they have a flare or a relapse. So this is the most common form of MS. Then there's also secondary progressive MS, which is that they started out having those flares or those relapses at the beginning of the disease. And then at some point in the disease, they just start to very slowly progress over time. And when I say progress, I mean, usually it involves accumulating weakness, accumulating disability, and accumulating different sensory symptoms. So like numbness, tingling, pain that starts to occur. That just starts to occur gradually. So the person's no longer having those flare-ups where they're getting worse and then getting better. And then there's primary progressive MS, which is the rarest. It occurs in 10% of people. And in those people, they start to progressively just become disabled over time. Without having those flare-ups. And that's a lot less common, but it does happen, unfortunately, and people can be very debilitated if they have primary progressive MS. So how do patients with MS do? So it's pretty unpredictable, unfortunately. I wish that there was a crystal ball and some way that we could tell patients how they're going to do, but we do have some characteristics that help predict whether someone's going to have better or worse outcomes. So 1/3 of patients have a mild disease course. So mild is just maybe they have a little bit of numbness in their fingers, some fatigue, but really they're not debilitated and they can like have a full-time job, have a, you know, pretty normal life with a good quality of life. 1/3 have a moderate disease course. So maybe there's some disability present, but they, you know, they can still do a lot of things on their own. And then 1/3 become disabled. So not being able to walk, and oftentimes they need help from other people to help them do their normal daily activities. And then some of the characteristics that predict a better outcome. So being female has a better outcome if you're younger than age 35, when you first start to have symptoms, sensory symptoms, instead of having actual weakness is a better predictor of better outcomes. Having less frequent relapses, and then completely recovering after a relapse is also a good predictor of not having severe disease outcomes. So the diagnosis of MS, it can be a little bit complicated. So the 2017 McDonald criteria is what we always refer to diagnose patients with MS. And it's a clinical diagnosis. So you do have to ask patients about, you know, going back to even childhood, if they ever developed any of those symptoms that I listed off earlier, because that could mean that if the patient had a flare up or a relapse in the past, and maybe it just wasn't identified as multiple sclerosis. So it's really important to ask about different signs and symptoms, medical history, and then MRIs is crucial. You can't diagnose multiple sclerosis without getting an MRI of the brain and of the spinal cord. And then lumbar punctures or spinal taps are optional, but usually we do have to do a spinal tap because there is useful information that we can get from the from the spinal fluid analysis. So to make the diagnosis, it requires what we call evidence of dissemination in time and space. So what does that mean? Dissemination in space means that there's evidence of lesions on the MRI, of the brain and the spinal cord, where there are lesions present in 2 of 4 separate areas. So you can see here, like I was showing, this is showing one specific area of the brain that's part of the McDonald's criteria. So that we call this periventricular because it's near the ventricle. And then there are other areas that we also want to look for too, like near the cortex, in the brainstem, for example. So this is the brainstem here, or in the spinal cord. So it's further down here. I have better pictures later on. So, and then there are other, and then dissemination in time just means that there have been 2 separate lesions that have occurred at 2 different time points. So it's just really important to go in depth in the patient's history to try to figure out if they've had 2 different time points where they had symptoms, because that could be considered a relapse. And then you also have to be sure that there aren't any other things that could mimic or imitate MS. So these are just some of the diseases that we sometimes think about. And then this is the very complicated McDonald's criteria. And I only show this because you can see it's pretty complex, but I kind of just summarized it on the prior slide. So we definitely use MRIs of the brain and the spinal cord in all patients. That's crucial to make the diagnosis because the McDonald's criteria require MRIs in order to make the diagnosis. And then these are just some other examples of a patient with MS. So this is a healthy brain, and this is just the side view of the brain. And then what you get are these plaques. So this is where the myelin starts to deteriorate. Remember the earlier slide where I showed you how the myelin deteriorates? So on MRI, it looks like this actually. So these are the plaques that develop in patients with MS. And you can see that they're here near the ventricle or the space that holds fluid. And then, I don't know if these pictures are very clear, but you can see it here. This is a comparison of a normal brain and spinal cord versus MS. But you can see here, none of those plaques or lesions that I was showing earlier. And then this is a patient with MS. They have those plaques or lesions where the myelin is deteriorating. It's pretty much in a lot of parts of the white matter. And then here in the spinal cord, this is the spinal cord here. So you don't see any white plaques. But here you can see that there are several white plaques throughout the spinal cord. So visual evoked potentials can also be used. Those also show if there's been, if the optic nerves have been affected, and lumbar puncture or a spinal tap can also be used. There's a particular protein that actually can tell us if a person has MS or not. So that protein is called oligoclonal bands. It's actually positive in more than 85% of people with MS. So it's a really important test. So it is important to recommend also doing a spinal tap. So this is the same slide that I showed earlier, but again, our MS treatments have improved over time, and there are so many more new treatments that are, being studied currently, and they're just not FDA approved yet. But I think in the next couple of years, we're going to have a huge influx of more MS medications. And one thing that I'll mention too is that progressively over time, these treatments have become more and more effective. So back in the 1990s, these treatments here, which were the injectable treatments, weren't very effective. We actually refer to these as low efficacy treatments. And then over time, these are all oral medications. So they're daily pills that the patient has to take to prevent relapses and to prevent further disability. So these are more effective than the ones back in the 1990s. And now we have even stronger medications, which actually suppress the immune system and prevent the overactive immune system from attacking the myelin sheath. So that's these medications here. And some of them are in pill form. This one's an infusion, so administered through an IV intravenously. So it really depends. But yeah, so we've seen really good success in being able to prevent disability in a lot of patients. And this is the same, just showing how the efficacy has changed over time. I won't go into all the details, but you can see that over time, our medications have become more and more effective in preventing relapses. So one of the other things that I really like about treating patients with MS is that it's actually a multidisciplinary approach. So we often need a lot of different specialties involved. So even though I'm just one neurologist, I actually end up referring a lot of my patients to urology or, working with patients with bladder issues, because the spinal cord actually controls how the bladder functions. So a lot of my patients actually have difficulty urinating or urinate too frequently. So it's important for them to see a urologist. A physiatrist, especially if they have spasms in their legs, can help with spasticity or with tightening of their legs. Physical therapy and occupational therapy are very important. If there's speech is involved, speech pathology is really important as well. I had also mentioned that depression and anxiety are actually quite common in patients with MS, and it's unclear if it's just part of the disease or if it's because of their level of disability just leads to depression and anxiety. But sometimes, oftentimes we do have to refer to psychology or psychiatry as well. And then neuropsychology, if they have any cognitive issues. We do have a social worker who works with us in our clinic. And I think social work is often very key, because you can imagine that, especially in patients who maybe their disease is not as well controlled, they end up developing more and more disability. So really getting them the resources to be able to take care of them at home is really important. So that's when social worker and care management is important. We have a pharmacy team that is dedicated to treating patients with MS. That's here at UNC. So it's really important to also collaborate very closely with the pharmacy team. And then also that their primary care doctors are aware of their treatment changes, because that can also affect any other conditions that they're taking medications for. So like I mentioned, there's two different treatments for MS. So we treat the flares or the relapses that I was showing earlier in that diagram. And usually we treat that. So when we suspect that a patient is having a flare up of their disease, that can actually lead to disability if it's not treated promptly. So we treat that with high dose steroids. Usually it's through the IV. We actually have a form of doing it administering it by mouth as well. But usually it's through the IV. And then we also treat to prevent these relapses from happening. Then we put them on those treatments that I was showing earlier, which we call disease modifying treatment. And these are all long-term treatments. I mean, most people have to be on these for life. Sometimes when they get older, usually by age 65, because their disease becomes a lot less active as they age, we can often consider taking them off of these treatments by age 65 if they haven't had active disease by that time. But you know, it essentially works by suppressing an overactive immune system. So a lot of these medications can have complications. If you're suppressing your immune system, I mean, you would imagine that you're susceptible to more infections, and long-term use of these medications can actually increase the risk of developing cancers as well. We also manage symptoms, so a lot of management of fatigue, different like pain, for example, we have to manage. So a lot of, you know, not just preventing the relapses and preventing disability by using the immune suppressing medication, but also managing their symptoms. And then rehabilitation. So I love referring my patients to physical therapy, and I think they love it too. They find it very, very useful and really feel like they get something out of it, and that their mobility actually improves with going to physical therapy routinely. And then psychosocial support is really important as well. And then I won't go into all these details, but we don't treat every single relapse. We treat the relapses that we think are, you know, going to lead to disability. And then usually we treat those with high dose IV steroids for 3 to 5 days, or we can use high dose oral steroids as well. And then if a patient has lost some level of function, we do refer them to physical therapy after they've had a relapse. And then again, like I mentioned, the disease modifying treatments are those long-term treatments that we use to help prevent relapses in multiple sclerosis. So they work to reduce the frequency of relapse. They also reduce the risk of developing new lesions or plaques that can be seen on the brain MRI and also on the cervical and thoracic spinal cord. And then it works to slow the disease progression as well. And it's always important to explain to patients that the medications do not cure the disease, they just work to reverse the symptoms. They don't reverse the symptoms and they don't cure the disease, they just work to help prevent relapses. And again, this is just the same diagram showing all the new treatments that we have out there right now. So we do have different disability assessments that we use to assess how they're walking. So we have different tests where we time how quickly they can walk 25 feet. And then we also have different medications that we can use to help improve their walking speed as well. And then I think it's really important also to manage weakness of patients' arms and legs that they can develop, because as you can imagine, it can really impair their quality of life and their ability to lead a normal life. So getting physical therapy very early on is important. Also making sure that they're safe, that they're not at risk for having frequent falls. So we often want to make sure that they have the assistive devices that they need, like a cane or a walker or a wheelchair. And these are just some other tools that we also use just to make sure that they can walk safely. And then, like I mentioned, we also want to manage MS-related fatigue as well. So I won't go into all the details about this, but fatigue can be very debilitating, and it's important to identify different factors that could be contributing to fatigue instead of just adding on a medication. Like, for example, if they're not sleeping well, that could certainly contribute to fatigue during the daytime as well. And then there are other reasons for patients being fatigued. And then I'll skip over this as well. And then vision problems is also really important to manage. Optic neuritis can cause blurriness of the vision, and then that can also impair somebody's ability to work or to be able to, you know, get through their day. So really important to treat that soon. I often do refer these patients to neuro-ophthalmology, who can make recommendations on how best to optimize their vision if they've had vision loss. Like, for example, if they've had double vision, ophthalmology can actually order prism glasses that help correct that double vision, so that way they could just see one image instead of two overlapping each other. And then I'll skip this too, but this is just a very nice picture of what the optic nerve looks like. And that's one of the images that the ophthalmologist can take to see if the optic nerve has been impacted. Okay, so I got to the cases now. Any questions so far? or should I go on to the cases? Okay.
Quick question.
Oh, sorry.
I had a quick question.
Sure.
Why does it kind of get better with age? Why does it stop affecting a person as they get older?
Yeah, that's a really good question. So the idea is that when you're younger, your immune system is actually stronger. But as you get older, I mean, like kind of like the same reason why COVID boosters were available to older people or earlier than like the younger people. It's because as you age, your immune system actually starts to decline. So it's assumed that because of that, because your immune system just naturally just starts to get weaker over time, that's why the disease just becomes less active. So I think that's a primary reason. I mean, we really don't know, but I think that's the reason that most people think of. So yeah, that's a good question.
Thank you.
Okay, so I'll go on to the cases. And these are actually my patients that I'm bringing up. So this is a 19-year-old Spanish-speaking woman from Mexico. Before she had actually immigrated to North Carolina 1 year before I started to see her in clinic, and just getting a really thorough history from her. She had started to have symptoms of MS back when she was 12 years old. So she unfortunately started to have symptoms of incoordination, so not being able to walk or being very uncoordinated. I was having difficulty walking without using a cane or without like leaning on somebody to walk. And then by age 15, she continued to have all these flare-ups of multiple sclerosis. By that point, she was already diagnosed in Mexico. They did do an MRI and they found that she had all those plaques in the MRI and she got diagnosed. So unfortunately in Mexico, just like in a lot of low to middle income countries, some of those newer medications that I was showing in that chart over time are not available. So she was treated with one of the first medications that actually became available to us in the US back in the 1990s, Copaxone. Like I mentioned, they're not particularly very effective, and especially in somebody who's young and is having frequent MS flares. I mean, here in the US, we don't start that medication. Unfortunately, this was the only medication that was available to her in Mexico. So her disability did continue to progress over time. And then I saw her when she was 19 years old, 18 years old, actually. Now she's 19. So she had been diagnosed with relapsing remitting MS, because like I mentioned, she was having all of these relapses and flare-ups of her disease and never really returning back to her baseline. And on my exam, she had what we call nystagmus. So that means that when she would look to the right or to the left, her eyes were disconjugate or not moving together. And that leads to nystagmus or shaking of the eyes. So she had a lot of double vision. She had a lot of difficulty walking too because of the double vision, and she had weakness in her right arm and leg. So she could still move her right arm and leg and she could still walk, but it was clearly weaker. Like she had a lot of difficulty kind of grasping objects with her right arm, or her right hand, I should say, and her right leg would kind of drag more than the left leg. And then she was pretty unstable when she would walk. So she kind of had to like lean on her boyfriend when she would walk. So this is her MRI. It's, for a 19-year-old, this is pretty advanced. So, you can see a lot of those plaques, those lesions that I was showing earlier. They're all over, near the ventricle, like I mentioned, and just, this is the white matter. So all of this is white matter. The gray matter is out here on the outside of the brain. But you can see that a lot of the white matter is involved. Over time, over time, you do get what we call black holes. So basically it's that there's loss of neurons in those areas, and there's no tissue there anymore. So that's why it shows up black here. So we call those black holes. It's not a very eloquent term, but that's what it's called. And you can see it here too. So yeah, so she was pretty debilitated at the time. So, and again, this is what a normal brain MRI looks like. So you can see you don't have any of those plaques. Just very clean looking brain. At least to me, it looks pretty clean. There aren't any of those plaques that I showed. And then this is her cervical spine. So in a normal, I think I might, Oh no, I thought I had a picture of a normal cervical spine, but in a normal cervical spine, you would expect this all to look gray, but you can see that it's white. So this is the area where there's been myelin loss, and it's all over the cervical spine, unfortunately. So again, she was on Copaxone at the time when she came to see me. It's not a very effective medication. And especially in a patient like this, who's young, having frequent relapses, has pretty advanced disability, I would start something more of higher efficacy. So I started a medication called ocrelizumab. It's a medication that suppresses the B cells of the immune system. So I don't know how much immunology you all have had, but your immune system is made up of B cells and T cells. So this only works specifically on the B cells. And this is just a diagram of how your B cells mature over time. So what it's doing is that it's suppressing the B cells from being active. And that way, the antibodies that you would expect are attacking the myelin sheath are no longer present because there's no B cells to make antibodies. So that's how ocrelizumab works. So started that medication on her, and I saw her in clinic, I think a couple of months ago, and she's actually doing pretty well. So, I mean, like I mentioned, these medications don't reverse disability. So she still has the weakness on the right side. She still has the double vision, but I did refer her to neuro-ophthalmology, and they gave her prism glasses. So now with the prism glasses, she doesn't have as much double vision. And overall, she feels well. She hasn't had any more relapses. So, even though some of that disability is still there, she hasn't had any more relapses. So hopefully, that'll stay like that. And, she, her disability will stay at this level and won't continue to progress. And that's just the same thing that we talked about earlier. So this is another case, another patient of mine. So this is a 44-year-old man, Caucasian male, who, when he came to see me, which I think I started seeing him 2 years ago, he had already been diagnosed with MS. So even dating back to 2007, so he must have been, it was a while ago, so he must have been in his 20s at the time. He developed left arm numbness and tingling, and then later on developed numbness of the right upper thigh. And he got diagnosed with MS at that time. They did an MRI of the brain and the spine and a lumbar puncture, and that's how they gave him the diagnosis. So initially in 2007, he got started on one of the oral medications called fingolimod. So it works on the immune system. So it does suppress both the B and the T cells. And during this time, while he was on Gilenya, he kept progressing and he was having more and more difficulty walking. He did have several rounds of steroids at the time, but even despite those steroids, he still felt like he was just slowly progressing over time. So it seemed like it wasn't those, discrete flare-ups or relapses. He was just kind of worsening just slowly over time. Then he got switched to another medication, which is also very effective medication called natalizumab. It's an infusion administered through the IV in an infusion center. It's given monthly. And during that time, he actually did pretty well. He didn't notice all that much disability progression. Then unfortunately in 2015, he was taken off of the treatment because he had a pretty bad urinary tract infection. So oftentimes when patients, if they develop, because like I mentioned, I mean, these medications are suppressing your immune system, you're at higher risk of developing infections. If somebody has an active infection, then we usually have to take them off of the treatment because then, the infection could get worse. So he got taken off of that treatment for 3 months. And then unfortunately, after he had this urinary tract infection, he developed significant disability to the point where he started to have to use a walker. He got transitioned to ocrelizumab, which was the B-cell medication that I mentioned earlier. And then while he was on ocrelizumab, he continued to progress. So it really seemed like natalizumab was the only medication that was really helping. So while he was on ocrelizumab, he started to progress and have to use a wheelchair. And he's wheelchair bound now. So then I in 2020, which is when I started to see him, I switched him back to Tysabri or I should say natalizumab, sorry, I use the brand name. I should be using the generic name. So I switched him back to natalizumab, and he's been stable since then. He does continue to be wheelchair bound, but he has really strong arms. So it's actually, I actually really admire that he's, you know, he leads a really active life. He has a very active social life. He tells me that he goes to concerts, and he's like able to live independently. So even though he's wheelchair bound, you know, he can still transfer himself like out of the wheelchair to bed, out of the wheelchair to the toilet. And he can do a lot of things on his own. He actually drives, and he uses, there are these special hand, it's like a, I don't know what we call it, a driving system that you can put on the car that allows you to move the car only with your hands. So he has that. So he's able to live like a very successful, independent life. So I think this is I demonstrated his story just because I think he's somebody who, you know, has really been affected by disability, yet has continued to live a really active, normal life. This is what his MRI looks like, his most recent MRI. So he does have a lot of those same plaques that I was showing earlier around the ventricle involving the white matter. I mean, you can see them here. This is just another view, and then this is the side view. And you can see that they extend all the way out here to the cortex. One of the other things that starts to happen too over time is that you can get thinning of the gray matter, which is that outside of the brain. It's not, he doesn't have that, but that was just something else that I thought I should mention, is that sometimes, especially as patients age, their brain starts to thin a little bit, and it can cause cognitive issues. So that is something that is pretty debilitating over time. So what kind of MS do you all think this patient has? So I talked about relapsing remitting MS, secondary progressive, and primary progressive. Does anybody, if anybody wants to shout it out or put it in the chat? Okay, so.
I was like, that's not just breaking it, that's breaking it.
Okay, well, somebody's talking there. Yeah, so secondary progressive MS, Alexis, that's correct. So he started out having relapses. I think I have that. Do I have that on the next? Yeah. So he started out having relapses back in 2006, I believe. And then at some point, he just felt like he started to slowly progress over time. So he has secondary progressive MS. And luckily, I mean, now on Tysabri, he feels like he really hasn't progressed all that much, which is good. And it is a little bit difficult to treat secondary progressive MS. So some takeaway points. I wanted to end early just to have time to answer questions. So some takeaway points is that MS is most common in young adults. It's less common for the reasons that I mentioned earlier about your immune system becoming less active over time. It's less common in older people. It's most common in young women. It's a chronic lifelong disease, but it's very treatable. So I think that's one of the reasons why I like treating patients with MS. The treatments do have side effects, unfortunately. So that is something that has to be weighed when you discuss risks versus benefits of these treatments. There's higher risk of infection, cancers. It can lead to liver toxicity as well. But it is very gratifying to help someone get better and prevent further disability. There is a national MS society, and each of the regions of the country has its own chapter. So this is the Greater Carolinas chapter, is our chapter here. And the MS Society is excellent. They provide so many different resources for patients with MS, and not just like, physical resources like, to help with their disability and things like that, but they also have courses, they have webinars for patients to be able to educate themselves on their disease. So it's a really nice society. And then this is just how to help patients with MS. There are support groups for patients with MS that are available through the National MS Society. And then there's also a Walk MS rally, in Raleigh. It happens yearly in April, and usually our UNC MS team, we always have a team that does the Walk MS rally, and there's also a bike MS too. I've never done it, but there is. So there's a lot of ways that you can get involved and help patients with MS. And then I'm happy to take any questions. And this is my email here. If you all want to email me, whether it's about MS or if you're interested in MS research or neuroinfectious or global health research, I'm open to having a discussion. So just let me know. So any questions?
Really quickly, similarly to my last question, do you guys know why it affects women more? Or is that just a statistic?
Yeah, that's a good question. We don't know why it affects women more. So I will say in general, women tend to be more affected by autoimmune diseases. So whether that be like lupus, rheumatoid arthritis, Sjogren's, I mean, there's a whole bunch of autoimmune diseases. They tend to unfortunately affect women more. So it's actually pretty interesting though, because changes in your estrogen levels when women, like for example, in women that become pregnant with MS, pregnancy is actually protective against having relapses or flares. And the thought is that because your hormones are changing so much and you have high estrogen levels, it's actually protective against having relapses. So oftentimes when patients become pregnant, we take them off of their treatment because some of these treatments are harmful to the fetus. And then breastfeeding is actually protective too. So we take them off of their medication usually, not just because it's harmful to the fetus, but also because a lot of patients, their disease kind of goes into hibernation when they become pregnant and while they're breastfeeding. So okay, so I think there are some questions in the chat actually. So is MS linked only to B cells? So that's a good question. So no, it's actually the B cells and the T cells are involved. But for some reason, but just this isolated B cell treatment that I was talking about earlier, ocrelizumab, it really, really helps in controlling the treatment, but or controlling the disease. But some of the other treatments that we have, like fingolimod and some of the oral treatments, work on both B and T cells, so they can they work on both. And then Laura asked, how long does it usually take for a patient to get correctly diagnosed with MS? That's a great question. I will say that it's hard to answer that question, to be honest, because I think one of the issues with MS is that there's not a lot of, even in neurology well, I'll go back. So even in internal medicine, like primary care doctors are not all that familiar with it because it's pretty rare. Like it's not like saying somebody has like diabetes or hypertension. It's a pretty rare disease when you think of like all the other diseases that are out there. So I think there's not a lot of familiarity with it by primary care doctors or just the doctors that routinely see patients, like family medicine, gynecologists, for example. And then even in neurology, we're exposed to multiple sclerosis, but it's not something that we see daily or all the time. So even if you if you go see a community neurologist, they may think about MS, but maybe they won't make the diagnosis correctly. And I think the other piece is because it's a really complex. I mean, I showed that diagram that shows like all the criteria the patient needs to make. I mean, it's kind of a complex disease to diagnose. So it can sometimes take a long time. I've had patients who unfortunately were misdiagnosed or told that they didn't have MS when like very clearly they had MS, and then they went like 3 years and became more disabled because they weren't on any sort of treatment. So yeah, it's hard to answer the question of like how long it takes, but it's just every patient is different and every physician, I think, has a different knowledge base of what they know of MS as. Okay, is stem cell therapy an option specifically to repair myelin sheath or regulate the immune system? That's a great question. So yes, there is stem cell therapy that it's called hematopoietic stem cell therapy. And yeah, so it's actually, the stem cell therapy is reserved for pretty much the cases that are refractory that haven't responded to any of the FDA approved treatments that we have out there. Because I mean, as you can imagine, stem cell therapy wipes out your entire immune system and you're replacing it with a brand new immune system. So this, I've only seen it done in 2 patients, and I have not done it myself. I mean, this was like something that I saw when I was in training and fellowship. But it's something that's reserved for like very, very severe cases that just don't respond to the treatments that we have out there. But it is a treatment that's available. And then a follow-up question is, what are some common misdiagnoses? Yeah, that's a really good question. So, I think it often depends on what the symptoms are. So I'd say, like, for example, if they're having numbness and tingling in their legs, somebody might think it's arthritis in their lumbar spine because they do have arthritis in their lumbar spine. So maybe they wouldn't think to get an MRI of the brain in that situation. If they're having numbness and tingling of their arms, then they might think, oh, it's, you know, a pinched nerve in their neck. So I think it depends. Now, there are some diseases that are kind of similar to MS or can mimic lesions in MS. So it's important to always rule those out. So for example, there are other autoimmune conditions like neuromyelitis optica. There's another one called MOG-associated disease. I mean, these all kind of look like MS, but they're not. And there are other infections too, like Lyme disease is one that we actually send off often when we're thinking about MS in a patient, because sometimes the lesions on the MRI can look like pretty similar to what we would see in Lyme disease involving the brain. So these are just some of the, and then also like vitamin deficiencies can cause those lesions too. So there's a lot of different misdiagnoses, unfortunately, and it just depends on like the workup and the management of the patient to try to get to the diagnosis. So any other questions? I think we're over time. So if anybody has any other questions, or if you just want to chat, just let me know. You can reach out to me.
Perfect. Well, thank you so much to all of the participants who were here, and even more so to Dr. Diaz for presenting with us for a second semester. That was an amazing presentation, and I know we all enjoyed it. I hope you have a good rest of your day, and I really appreciate the time that you took out of your day for us.
Okay, thank you. Take care.